Yes, ma'am. We are live, ma'am.
So, good evening, all. So, this is the first type of webinar conducted by 4 states of South, Andhra Pradesh, Karnataka, Tamil Nadu, and Telangana. So, now I want to start the program by introducing Dr. Shanta Durge.
Maybe we'll have a prayer song first.
So, please play
Prayer song.
song.
And lighting the lamp.
So, myself, Dr. Radha Lakshmi, Professor of OBG, presently working as Secretary of Kurnool OBG Society since 2022. I am also in charge of Mission Pink Health IMA Kurnool. So I want to start the program by introducing Dr. Shanta Durge. Shanta Durge is the Clinical Director and Clinical Consultant at Durga Clinic Fertility Center, Basava Kalyan. She is the founder, president of Basava Kalyan, and she is nominated member of the Karnataka State Assembly Supervisory Board PCPNDT, recipient of Korean Award, many poster awards and AICOG, many state awards, faculty at many AICOG state conferences till today. And she is importantly Kasuga Chairperson for Public Awareness Committee 2023. Now she is also contesting for the post of Chairperson Public Awareness Committee 2026. And she had more than 40 write-ups on female feticide in Marathi News Daily, wrote novels on female feticide, activist for the Save the Girl Child and to protect girls' rights movement since 26 years. I request Shanta Durge Madam to introduce Dr. Durgadas Asaranna sir. And one more convener along with me is Dr. Vijaya. She is the past president of OGSSI since 2024 to 25, former director, Institute of Obstetrics and Gynecology, Madras Medical College, former director, Institute of Social Obstetrics and Gynecology, MMC, Best Doctor Award during COVID pandemic, state level master trainer in EMOC, state level master trainer in cervical cancer screening and colposcopy, national master trainer in safe delivery practices and Dakshata, and Foxy master trainer in HPV awareness program. And she conducted Aksharam webinar series in April 2024 to March 25 by OGSSI Medical Education Committee. Presently, she is contesting for the post of Chairperson, Medical Education Committee, Foxy. Now I request Shanta Durga Madam to introduce Dr. Durgadas Asaranna sir, the guest of honor.
Thank you, Dr. Radha, for a nice introduction. First of all, we all 4 states are conducting this 4 states webinar on today's topic. And Dr. Durgadas Asaranna sir, the vibrant and most dynamic and pleasant personality of Karnataka Association's president. Despite his busy schedule, he has accepted our invitation as a guest of honor. And he is the member of IMS, member of ISOPAB, past president, TSOG, Tumkur Society, and associate professor in Sri Siddhartha Medical College, Tumkur, and consultant in Kasturba Hospital, Tumkur. So, sir, we need your presence here at the webinar, and please join earliest. And even you have to bless all the conveners, all 3 conveners, sir. Thank you. Over to
Vijaya.
Dr. Radha. Yeah.
So I request Vijaya to introduce Dr. Charmila Ayava Madam, the Vice President of Foxy 2024. She is the chief guest of today's webinar.
Yeah, thank you, Radha, for the nice introduction. And I have great pleasure in introducing one of my close and best friend, Dr. Charmila Ayyavu. And she's a very friendly and helpful in all of us. Whenever we have some problems, I just call her and she will give me the solution. And she's the director, Aditi Hospital and Parvati Ayyavu Fertility Center, Trichy. And she is the assistant professor in Dhanalakshmi Srinivasan Medical College, Perambalur, associate professor, and consultant in Railway Hospital, Trichy. Vice President Foxy 2024, Vice President Trichy OG Society, and she's a Secretary Gestosis India Association, and she is the Managing Committee member, PCOS Society of India, and ICOG Governing Council member 21 to 26, and Administrator A+ in High Risk Pregnancy Care Foxy, National Coordinator for Foxy UNICEF PCA, and Series Convener in ICOG Certificate Courses and Journal Club 21 to 25, and Chairperson Clinical Research Committee Foxy in 2016 to 18. Welcome, Charmila. We are privileged and proud to be you are here with us. Thank you.
And Charmila madam is the inspiration for many secretaries and presidents in the South. Thank you, madam, being the chief guest of our webinar. And I request you to tell few words of your wisdom, madam.
Madam, unmute. Charmila,
Unmute பண்ணுங்க.
not audible.
Not able to hear you, madam.
Not yet.
No, we cannot hear you, ma'am.
Oh, no, not audible, madam.
Is she there?
Yes, ma'am has joined, but not able to hear.
She'll connect. Can you help? We're not able to hear madam speaking.
Sagiti?
Yes, ma'am. Ma'am, have you connected to any earphones or something, ma'am?
Earphones. Disconnect the earphones, madam.
She's not seen there.
No, audible, not audible.
Ma'am's presence is not seen there. I
No,
don't-
now it's unmute. You have to unmute.
I think ma'am has joined from mobile.
Unmute, Charmila.
I'm so sorry for the disturbance.
Yeah.
I'm so sorry.
It's okay. Now audible.
I leave the other one. Yeah. I'm so sorry. I'm most of you like who are there are all my friends. And it's an honor to be in a program where I'm seeing Dr. Shanta Durge, Dr. Vijaya, as well as Dr. Radha, as well as my friends Umayal, and I'm seeing Aruna also. So it's a great honor to be in the program. Good evening, Venkatraman sir.
Charmila, Bharti also.
And I'm honored that all of you have asked me to join this program because I know all of you are like people who have worked so hard in your own places, and now you would like to move into the national scene. And such hardworking people should always come into Foxy, and because we grow with each other and we learn from each other. So having you all together in a program is it's such a pleasure to see all of you. And I would like to wish each one of you the best. And you are arranging such great webinars also, all with so much of academic content, which I know South is very famous for. We do academically well, but you have never shown ourselves outside. But I think it's time that everybody in South also moves into the national arena. And I would like to wish all of you the best. And thank you so much for this opportunity. The best of luck, and we'll always be with all of you. Thank you so much.
Dr. Shamila, can you hear me? Bharti here. Can you hear me?
Yes, Bharati.
How are you? Nice to see
Bharati
you
is going
after
for
long time.
North Zone Vice President, and she's a
Yeah.
very, very hardworking person. I think we should all support her in this endeavor because she deserves it, because she works so hard for the society as well as for Foxy. Best
Thank
wishes,
you,
Bharati.
thank you.
Yeah.
Thanks.
I think Sir has joined us.
MC Patel sir joined.
Oh, the other person.
Good evening. Good evening,
Durga
sir.
Das sir.
Venkatraman sir has joined.
Okay. Then we can ask Bharti ma'am, introduce Bharti ma'am, no? Shanta ma'am.
Yeah. Please. CV of Dr. Bharti ma'am, Saiti.
CV of Dr. Bharti. Sagiti.
Chairpersons are there, ma'am. Please introduce chairpersons.
Yes.
Yeah.
See, this is a very nice thing for me that I am going to introduce Dr. Aruna Suman. She is the even candidate for the FOXI 25, and she is the professor OBG HOD at the Government Medical College, Joint Secretary FOXI 2021, even at Hyderabad, AI Shivaji. She was the organizing secretary, national coordinator to No to Violence Against Women Committee, and member of so many committees. She is the trainer of trainers, National Health Mission. And so many things for her. So, Dr. Aruna Suman, a very famous personality in South. And now, I think I will introduce Dr. Umayan.
Yes.
Beta.
Yeah. Dr. Umayan from the Tamil Nadu, who is the managing director of Sri Kumaran Specialty Hospital.
Screen गायब हो गया इधर से आके देखो
Can you hear me? Can
Yeah.
you hear me?
Yes, ma'am.
She is the managing director of Sri Kumaran Specialty Hospital, Tambaram, Chennai, and she is the president, Kanchipuram Obstetric and Gynecological Society, organizing secretary of South Zone VP Conference 2024, and IMA past president, Tambaram, and chairperson, Women's Wing, IMA Tamil Nadu State, and State Council and Central Council member of IMA. So welcome, Dr. Umayan.
So
Thank
I
you.
request Aruna Suman to introduce Dr. Bharti Madam.
Thank you
Aruna?
very much. Good evening, everyone. Thank you very much for this opportunity, Dr. Radha Lakshmi, Dr. Shanta Durge ma'am. Thank you so much. And namaskar to MC Patel sir and dear Charmila Ayavu madam. I feel very happy to share this platform with you, and it feels wonderful to introduce dear friend who is very cool and composed. She will definitely make a good leader. She's none other than Professor Bharati Maheshwari. She is head of the department at Muzaffarnagar Medical College. So she is a diploma in IVF and reproductive medicine, Germany, fellowship in medical education in MCI, FIME, chairperson FOXI MTP Committee 18 to 20, governing council member ICOG, secretary UPCOG, president Meerut OB-GYN Society, president Meerut ISOPAB, president Meerut Menopause Society, chairperson ISOPAB Family Welfare and Reproductive Medicine Committee, published papers and review articles in Index Journal, delivered Kamini Rao oration and other talks in national and international conferences, organized North Zone and UPCOG conference as organizing secretary, national coordinator MTP Committee 2015-18, and executive member of Endocrinology Committee, Public Awareness Committee, and Medical Education. I welcome you, Dr. Bharati Maheshwari. Feel very nice that you are there here with us. Thank you so much, and I welcome you.
Thank you. Thank you, Dr. Aruna. And thanks all for making me a part of this prestigious webinar. What you have said, that is 4 South states, 4 states, all of South. And you all are my very good friends for a long time, as we all know. And I am just going to share my slides because of some technical reasons.
Switch on your video, please.
Pardon?
Can you switch on your video?
Okay. It is.
We would like to see.
Can you see me? I think you should.
Slides are seen now.
Actually, yeah. I think now you can see.
Slides are seen now.
And my picture is also.
Your picture is
not able to. We are able to see the slide, but not you, Dr. Bharati. Please make sure.
Okay.
Now, yes.
Now it is there.
Okay. So thank you very much. And congratulations to all conveners, Dr. V. Radha Lakshmi, Dr. Shanta Durge, and Dr. Vijay. And I know you all are such a, I should say, academic pearl of the country, and you should get your position, what do you want, and you are truly deserving. Dr. Aruna Suman, same here. And Dr. Omigyal Merugasan, she's also very deserving person. So best wishes to all of you. And regards to Dr. Durga Das and Dr. Shamila, and all senior persons, Dr. M.C. Patel, Dr. Venkataraman, Dr. C.V. Rama Rao, and all senior persons there. So thank you very much. And with this regard, I comes to you that as a MTP committee chairperson, I done lots of interactions all over country and met all of you. And in this series, and today's whatever I am giving to talk, that is on intrapartum fetal surveillance. So all we know that it means assessment of fetal well-being from passage of intrauterine life to extrauterine life. So why it is important, we all know that it is to just detect acute hypoxia, either due to hyperstimulation, either due to placental abruptio or umbilical cord accident. So we clinicians should be able to recognize these events to intervene. So basically the timely intervention and rescue of fetus at risk of neonatal and long-term morbidity from intrapartum hypoxic insult. So what are the current options available for intrapartum fetal surveillance? First is intermittent intelligent auscultation. We should never forget it. Then electronic fetal monitoring, fetal scalp blood sampling, fetal scalp lactate test, stimulation test, fetal pulse oximetry, ECG, and clinical assessment. Intermittent auscultation, we can do either by Penard or handheld Doppler alone enough for low risk pregnancy. First stage, it should be auscultated for 1 minute soon after contraction in each 15-minute gap. Second stage at every 5 minutes interval. And actually, what do you mean by intelligent auscultation? Feel for fetal movement and listen fetal heart sound more than 15 beats per minute increment during this and during acceleration. After contraction, look for any reduction of fetal heart sound, that is called deceleration. If movement associated FHS is noticed, then CTG also likely to be reactive. So this is the interpretation of fetal heart rate sound. So what are the important intrapartum monitoring tool? I have already told you. So a very important tool, that is CTG, cardio tachography. So as it is said in the confidential meeting, that most of the criticism is focused on electronic fetal monitoring. And most important issues are that failure to initiate CTG when indicated, failure to initiate good quality CTG, as well as inadequate CTG interpretation, and failure to communicate to the senior staff in timely manner. So we all know the CTG are tests used in pregnancy to monitor both fetal heart rate as well as uterine contraction. It should only use in the third trimester when fetal neural reflexes are present. Its purpose is to monitor fetal well-being and allow early detection of fetal distress, antenatal or intrapartum. Abnormal CTG indicates need for further invasive investigation, and untimely may lead to emergency cesarean section. So questions come when to do CTG. So maternal indication, all high-risk pregnancies, bad obstetrical history, post-natal pregnancy, fetal indication, reduced fetal movement, suspected fetal growth restriction, abnormal fetal heart rate by auscultation, multiple pregnancies, recent isotonialization, and before induction of labor. What is the frequency of testing? Normally, if everything is okay, you can do every 7 days, but twice weekly testing is advocated in some cases like post-natal pregnancy, diabetes, fetal growth restriction, gestational hypertension. Additional testing is performed for maternal or fetal deterioration regardless of time elapsed. Other perform non-stress tests daily or even more frequently. We all are familiar with the CTG machine. We all know it can be, application can be either transducer is applied externally or mother abdomen, or internally or the fetal head. Normally we use the external transducer, and setting of CTG machine is also, we should be aware of that on horizontal scale, the paper speed can be 1, 2, or 3 centimeter per minute. On vertical scale, sensitivity displays are said to be 20 or 30 beats per minute. FHR ranges displays 30 to 240, and uterine activity internally 0 to 100 millimeter of mercury, and externally also 0 to 100 relative units. And you can say that paper speed as well as horizontal scale on the vertical scale, and you can see that the fetal heart rate is displayed from 30 to 240, and contractions you can see from 0 to 100. So setting of CTG machine ideal, what is ideal? 3 centimeter is more accurate for abnormalities, but 1 centimeter is done when less paper but less accurate and used for screening. Acoustic stimulation test. We all should be aware of that also, because provoking acceleration of fetal heart rate, the acoustic stimulation is positioned on the maternal abdomen under stimulus for 1 to 2 seconds. It may be repeated up to 3 times. It shortened the average time for non-stress test, and it is testing from 24 to 15 minutes. Now comes to the interpretation of CTG. This is a very important part, and here I have bring you a very smart way to remember in the structured way, that is using the acronyms DRC Bravado. DR means define risk. In every patient, you have to first define the risk. Second, C for contraction, BRA baseline rate, V variability, A for acceleration, D for deceleration, and overall impression. So you have to interpret in this structured manner. So define the risk. If pregnancy is high risk, then threshold for intervening may be lowered. So these are the all high risk factors you must define once you enroll the patient. Contraction, you can see in there are 2 to 3 contraction in 10-minute period. So you have to see 10 boxes, 10 big boxes, and here you can see that how many contractions are there. That has to be noticed. Besides that comes to the baseline rate of fetal heart rate. Look at the CTG and assess what the average heart rate has been over the last 10 minutes. Ignore any acceleration or deceleration. A normal fetal heart rate is between 120 to 160 beats per minute. In this picture, you can see that in 10 minutes, you can see baseline fetal heart rate 140 per minute, and ignore any acceleration or deceleration, and you have to take average fetal heart rate. And tachycardia or bradycardia, once it is more than 160, then you have to take care of. It could be due to fetal hypoxia, choriomyelitis, hyperthyroidism, anemia, or tachyarrhythmia. And if it is low, less than 120, and mild bradycardia when 100 to 120 could be due to phase 4 stated, occipito-posterior or transverse presentation. Severe prolonged bradycardia when less than 80 for more than 3 minutes, then it is either due to severe hypoxia, prolonged cord compression, cord prolapse, epidural and spinal anesthesia, maternal seizures, or rapid fetal death. If the causes of tachy or bradycardia cannot be identified and corrected, then immediately delivery is recommended. Then come to very important part after DR, define risk, C for contraction, BRA basal heart rate, then come to variability. Variability refers to the variation of fetal heart from one beat to the next. It is result of interaction between the nervous system, chemoreceptors, baroreceptors, and cardiac responsiveness. Therefore, it is good indicator of how healthy the fetus is at the time. This is because of healthy fetus will constantly be adapting its heart rate to respond to change in its environment. Normal variability is between 10 to 25 beats per minute. To calculate variability, you look at how much the peak and troughs of the heart rate deviate from the baseline rate in beats per minute. Now this is picture, you can see the variability. Here you can see the variability, reassuring when it is more than 5 beats per minute, non-reassuring when variability is less than 5 or between, and it persists for 40 to 90 minutes. Abnormal when less than 5 beats persists for more than 90 minutes. So here you can see even more zigzag, then it is good variability. And it should be 5 to 20 ideally. Reduced variability, you can see the picture look like this in the CTG. If variability is reduced, it is more like the flat. So it could be either fetal sleeping or hypoxia or fetal tachycardia or some drug like Mexels, methyl-dopa, prematurity, and congenital fetal heart rate abnormality. So detailed history of for all these factors should be found out. Then DR defines this, C for contraction, BRA baseline natal heart rate, B for variability. After that comes acceleration. Acceleration are an abrupt increase in baseline heart rate of more than 15 beats for more than 15 seconds. Its presence is reassuring. Antenatally, there should be at least 2 acceleration every 15 minutes. Acceleration occurring alongside uterine contraction, it is a sign of healthy fetus. However, the absence of acceleration with an otherwise normal CTG is of uncertain significance. So you can see that, this is acceleration, and in relation to uterine contraction, you have to see it. Deceleration. The deceleration are an abrupt decrease in the baseline fetal heart rate. Again, same criteria, more than 15 beats per minute for more than 15 beats per second. There are a number of different types of deceleration, and they are normally interpreted in relation to uterine contraction. And it could be early deceleration, variable deceleration, late deceleration, prolonged deceleration, and sinusoidal pattern. So what do you mean by early deceleration? Early deceleration start when uterine contraction begin. In this picture, you can see that early deceleration, here uterine contraction begin. Here you can say, and it start, and it recover when uterine contraction stop. So before ending the uterine contraction, it recover. This is due to increased fetal intracranial pressure causing increased vagal tone. It therefore quickly resolves once the uterine contraction ends and intracranial pressure reduces. This type of deceleration is therefore considered as physiological. Then come to variable deceleration. They are variable in their duration, may not have any relationship to uterine contraction, more often seen during labor and in patients with reduced amniotic fluid. And because it is mainly caused by umbilical cord compression. The umbilical vein is often occluded first, causing an oscillation in response. Then umbilical artery is occluded, causing a subsequent rapid deceleration. When pressure on the cord is reduced, another oscillation occurs, and then the baseline rate returns. Oscillation before and after a variable deceleration is known as shoulder of deceleration, and their pictures indicate that fetus is not yet hypoxic and adapting to reduced blood flow. In this picture, you can see variable deceleration that they sometimes resolve if mother changes position. The presence of persistent variable deceleration, of course, they need for close monitoring. Variable deceleration without the shoulder is more worrying, as it suggests the fetus is hypoxic. So once you are seeing the deceleration, you correlate it with uterine contraction. Here you can see that it is persisting even after uterine contraction ends. Here you can see that it is initiating, deceleration initiating at the early of uterine contraction. So they are variable in the onset and ending. And here you always see if there is a small deceleration just before the small oscillation just before the deceleration, then it is always a good sign. Then comes to the late deceleration. Here you can see that late deceleration, they start and once the contraction of uterine is about to end and they persist for longer time. So late deceleration, they are mainly because of insufficient blood flow through the uterus and placenta. As a result, blood flow to fetus is significantly reduced, causing fetal hypoxia and acidosis. Reduced uteroplacenta blood flow can be caused by either maternal hypotension, preeclampsia, and uterine hyperstimulation. The presence of late deceleration, it is taken seriously, and fetal blood sampling for pH is indicated. If fetal blood pH is acidotic, indicates significant fetal hypoxia and immediately intervention is required. Then comes to prolonged deceleration. The picture you can see that deceleration and they are persisting for more than 2 minutes. Once it is persisting for more than 2 to 3 minutes and it is deceleration, it is called non-reassuring. And if it is more than 3 minutes, it is called abnormal. So action has to be taken quickly, either cesarean section or fetal blood sampling. So these are the 4 types of deceleration I have compared in the one slide. You can see early deceleration. They are mainly because of fetal movement. They are mainly associated physically and they can be recovered when the fetal movement stimulation or uterine contraction. The late deceleration with preserved viability. The variability is there and late deceleration is there, and it is mainly due to uteroplacental insufficiency or decreased uterine blood flow. Then come to variable deceleration. I have already told you could be because of compression of the cord, and they are also, one has to see, this is, you can see shoulder sign, oscillation just before the deceleration. This is always a good sign and you can manage the patient conservatively with close monitoring. Severe variable deceleration. Here you can see that deceleation data, the relation to uterine contraction, it is not fixed. Long deceleration below 70 beats per minute. So this is the significant, and it could be due to fetal hypoxia or distress. So this deceleration, once you see any picture of CTG, you see the 4 things. First, you identify any high risk factor. Then you see the contractions, how many contractions in 10 minutes. Then you see the fetal heart rate. Then you see oscillation, variability. Then you see variability, oscillation, and deceleration. The last type of deceleration, that is sinusoidal pattern. How it look like? It look like a spring coil. You can see in this picture. And this is rare, and it is mainly described as a smooth regular wave-like pattern, and its frequency is around 2 to 5 cycles a minute. Stable baseline rate around 120 to 160 beats per minute, no beat to beat variability. And this pattern indicates severe fetal hypoxemia, anemia, hemorrhage, and immediately C-section is indicated. So after recording all these things, last O, that comes to overall impression. Once you find out all these observations, then how you should write down the report. So it should be in the 3 words only: reassuring, suspicious, or pathological. So how you find out that this CTG is reassuring, this is suspicious, this is pathological? When the overall impression is determined how many of CTG feature were either reassuring, non-reassuring, or abnormal. We say normal CTG when all 4 features are classified as reassuring. So what is reassuring here? You can see this is a chart, FIGO chart. You should keep this in your working station. And here you said that the baseline fetal heart rate, variability, deceleration, oscillation, they all are in the normal criteria. Then it is reassuring. Non-reassuring when they are in between the normal and abnormal, then it is non-reassuring. All these 3 criteria has been taken as an impression. Abnormal when baseline fetal heart rate either bradycardia or tachycardia less than 100, more than 180, or sinusoidal pattern or variability is less than 5 for 90 minutes. Deceleration, they are present and they are occupying over 50% of contraction. Late deceleration means they are persisting for over 30 minutes or more than 30 minutes. Single prolonged deceleration for more than 3 minutes. So these all are in the criteria of abnormal. So if all 4 features are classified normal, then it is classified as reassuring. If suspicious CTG, when one feature is classified as non-reassuring, while other are reassuring, then it is called suspicious. If more than 2 features are non-reassuring and more than 1 feature classified as abnormal, it is called pathological. So you have to write down either reassuring CTG or suspicious CTG or pathological CTG on the basis of these tables: reassuring, non-reassuring, and abnormal. Then comes to intramartum fetal monitoring, then uncomplicated pregnancy. So it is said that for a woman who is healthy and has no high risk factors, intermittent auscultation is also a good method of monitoring. And in the active stage of labor, intermittent auscultation should occur after a contraction, minimum of 1 minute, and at least every 15 minutes in first stage, every 5 minutes in the second stage. Maternal pulse should also be palpated if FHR abnormality detected to differentiate the 2 heart rates. Now, the continuous fetal monitoring in low risk women, what are the indications? If woman is having significant or light liquid mistake like a abnormal FHR detected by intermittent auscultation, maternal pyrexia, fresh bleeding developing in labor, oxytocin use of augmentation, and woman's request. In these cases, even in the low risk women, you can do continuous fetal monitoring. But the fact says that there are the borderline evidence that continuous EFM were more likely to have an instrumental birth compared with the auscultation group in the low risk women, although there are no evidence of differences in augmentation, perinatal mortality, and other neonatal morbidity. So these are some live situations where it is told about the significance of CTG monitoring. It is WHO situation where a mother with history of previous seizure was admitted in early labor and had CTG monitoring with an epidural. CTG became difficult to interpret with suspected high baseline and variable deceleration. When an examination was done, 9 cm dilated. After 1 hour, it was noted that tachograph was not recording the uterine contraction and they were no longer probable abdominally. After discussion with consultant, it is said that start the IV oxytocin, and again the instrumental delivery was tried, and CTG was described as reassuring. However, on retrospective view, it is said that heart rate was not a fetal heart rate, actually it was maternal heart rate 120 beats per minute. And it seems like that the CTG is maternal rather than fetal pulse. And the obstetric registrar perform a forceps delivery of a stillborn birth. They have managed conservatively in a view that CTG is normal. This was followed by fresh vaginal bleeding, which persisted after the repair of perineal tear. The consultant attended, and when the mother started to complain of shoulder pain, then possibility of rupture was considered, and second consultant was called, and laparoscopy was done and found uterine rupture. So message is that one has to be alert to the other aspect of CTG, that is tachograph. If one had a sudden loss of contraction in a mother with a previous C-section, The being considered more thoroughly, the diagnosis of uterine rupture may have been made, either preventing the outcome. Then another case, either again the woman is continuous CTG was done, prolonged ventilation was found, mother was transferred to OT, fetal heart rate recovered, and she was again transferred to delivery room. ARM was done with the plan to perform ARM if deceleration persisted. After a further deceleration, ARM was done at 4 centimeter dilatation, revealing thick meconium. Fetal heart become difficult to monitor. Attempt to place a fetal heart scalp electrode more than 30 minutes, but again not found fetal heart rate properly. When a second CT machine is also used, that could not also succeeded, then the obstetric registrar was asked to perform an ultrasound. Unfetal bradycardia was found and cesarean was done. So message is, when a fetal heart rate become undetectable, maternity team need to be act quickly to ensure that fetal heart rate is satisfactory or not. Although fetal scalp electrode, they are a good method, but sometimes it can be can still be unreliable and can take time to establish good rate. So good quality continuous recording of both fetal heart rate and uterine contraction are a critical prerequisite for adequate CTG interpretation. So whenever you are taking decision on the basis of CTG, you have to ensure these two things. Trying to achieve this in timely manner can be intrusive, but it is the duty of health provider when appropriate to find a way to adequate monitor women and their babies in labor. So ultrasound scanning should be used to exclude severe fetal heart rate abnormalities when a CTG recording cannot be obtained reliably by a transabnormal transducer or fetal scalp electrode. So recognition of a prompt action when faced with a pathological CTG, a significant proportion of reviews identified that professionals either didn't recognize pathological CTG or didn't act upon pathological CTG even when it was recognized. So finally, when we take the decision in relation to CTG, we should always take care. We must take into account the full picture of the woman, full clinical picture, including mother history, stage and progress in labor, any antenatal risk factors, any other sign that baby may not be coping with labor. A CTG should not be reviewed as a standalone investigation. So these are the different clinical picture. Like the woman, she is 36 weeks of pregnancy with mild labor pain and comes to you with a not perceiving fetal movement properly. On examination, everything is normal and you find 1 to 2 contractions, FHS is present, and PV you find that vaginal examination 2 centimeter dilated, a bit soft, early labor, and show present pelvis seem to be adequate. Bishop score is 4. Basic investigations are normal. CTD, you see CTD, you can see the picture of CTD. That in the relation to uterine contraction, you can see early deceleration. And they are of only 10 seconds. No acceleration, of course, basal average fetal heart rate is 130. Beat to beat variability present. So what is the interpretation? Patient counseling is the high risk prognosis explained. Observe for spontaneous progress of labor, shifted are in the left lateral position, oxygen and lateral fluid are given, and again, if it is reassuring, then of course one can observe for spontaneous, but after this, if it becomes reassuring, then one can intervene. So this is the very important slide where you can see that criteria for categorizing the or helpful for the taking the decision for abnormal CTG. Category 1, category 3, category 2. All of, if the category 1 criteria are present in the tracing, then you must think that you can keep the patient for the observation. And if category 3 criteria are present in the patient, then you should think that you have to do like patient can have a certain abnormalities and you have to act immediately. And if the FHR tracing does not meet criteria of either 1 or 3, it comes in the 2. And then again, you have to think for the observe the patient. So in the category 1, where you can keep the conservative, when there is a baseline fetal heart rate is normal, more moderate baseline variability is there, no late or variable deceleration. Early deceleration may be present or absent, acceleration may be present or absent. But bad criteria where you think that fetus can be hypoxic when absent baseline fetal heart rate variability and any of the following: recurrent late deceleration, variable deceleration, bradycardia, or sinusoidal pattern. So on the basis of these criteria, you can take the decision. So this is again a real patient where she come to you with 32 weeks of pregnancy with oligohydramnios and derange umbilical artery Doppler. On CTG, we can find out that fetal heart rate is okay, no acceleration, beat to beat variability present, but long late acceleration. So again, it is an indication for time intervening. And another patient then is come to you that she is again having the leaking per vaginum, and she's a 37-week pregnancy. And of course, in the PV, you see her and Bishop score is 8, Leica is clear. But on CTG, you think that variable deceleration of 15 beats per minute for 15 seconds. Beat to variability is present, rest all is normal. Then again, in this patient, there could be sudden drop of fetal heart rate. So of course, it could be a cord prolapse, foot end should be elevated. Patient is PV examination. If it is confirmed, then of course, immediate cesarean section should be done. But if there is no cord prolapse, the patient in the left lateral position, IV fluid oxygen can be given. So these are the certain CTG normal pictures. I'm not going to take all because time is limited. So this was about the intrapartum fetal surveillance. As CT is very important options. And then another thing comes fetal scalp blood sampling. This should not be the choice if pre-terminal CTG pattern or clinical situation is happening. Like it is only useful when there is a prolonged bradycardia, markedly reduced variability, late atypical deceleration, cord accident. So, but this is contraindicated when known bleeding diathesis or transmissible infection is present. So here, those who are doing that, they know that there is a particular instrument and how they take the drop of blood from the fetus and they take the pH value. They might not reflect hypoxia acidosis in some situation. And if pH value is less than 7.2, then immediate debride is recommended. 7.2 to 7.25, repeat again in half hour. More than 7.25, then observe for CTG improvement and repeat if necessary. Good clinical assessment and CTG reduces need of scalp sampling. So I know that this is not a first line investigation. Fetal stimulation test, we already told, a scalp stimulation with either Ellis tissue or vibroacoustic stimulation across maternal abdomen is used. And if there is no response, then nearly 50% chances of fetal acidosis. Fetal pulse oximetry. Fetal pulse oximetry, SpO2 fluctuates in fetus at 38% to 80%. If it is less than 30% for 10 minutes or more, immediate delivery plan is required. This is also an application of a scalp electrode and interpretation as electronic machine reading. Fetal scalp lactate sampling. Metabolic acidosis is reflected by pH and the lactate level. If hypoxia for more than 10 minutes, lactate begin to build up in fetal blood. Longer the duration, accumulation also more, but its disappearance is more time consuming. So scalp lactate level correlate with umbilical cord blood lactate level. So while lactate is more effective in detection method when compared with fetal blood sampling, because it needs only 1.1/7 volume of sample for FPS. So it is important. And how to interpret lactate level less than 4.2 normal. If CTG changes still present, consider to repeat in 1 hour. 4.2 to 4.8 pre-acidemia, repeat in 30 minutes or deliver a significant rise from last value. More than 4.8 acidemia, immediate delivery is needed. Then another, so this was about the fetal blood sampling. I have told you fetal blood lactate level and SpO2 level and fetal ECG analysis. This is also one method where one can find out. Here scalp electrode is used together with maternal skin electrode analyzed using ST wave analyzer. And the ST segment divided by T wave elevation. They favor hypoxic event in the myocardium at renal insertion. Such myocardial ischemic changes is related to cardiac glycogen content. So this ECG rise of T upon QRS ratio increasing ST4 waveform reading, they have to be read. And biphasic ST waveform, if the ST wave is above the isoelectric line, then it is called BST1. If it cut the line, then it is called BST2. And if changes below the isoelectric line, then BST3. So this change is due to ventricular repolarization and current flow from endocardium to epicardium. Preterm fetuses show these changes, hence fetal ECG is not applicable to preterm fetuses. Then this is also, you can see that combined interpretation by CTG as well as T by QRS, right? And on the guideline of the basis of this, you can decide the combination and you can decide the status of fetal distress. Fetal ECG plus CTG co-use have reduced the need of fetal blood sampling. Fetal acidosis and operative delivery date. This is in the certain research study says. Clinical assessment. So we always should be very much alert for doing the proper clinical examination. And the last word on the meconium, as can be used to recognize ongoing fetal adverse event and should correlate with other decision method. So when it appears usually at term but rare in the preterm unless listeriosis like infection or hypoxic event. At term, this indicates functional maturity and as with date, read postterm incidence is 5% versus 15%. But after prostaglandin induction is another reason as PG increases gut motility. Alternative explanation is anal sphincter relaxation and hypoxia causes meconium passage. So it is not common to find meconium in endohypoxia like cord prolapse or abruptio. Meconium does not always sense that fetus is in trouble. So both things are with the meconium. It is not always present in the distal, but it does not always show that fetus is in distress. Unclear liquor is not promising for well-accelerated fetus, so use this finding wisely without getting into the trouble. So together we should know the indication of all intrapartum monitoring tool and we should use, but again the very important is 3-tiered fetal heart rate interpretation system, and we all should know that how the whole fetus hypoxia can be assessed, and again CTG how it should be properly interpreted. So if some abnormality is there in the CTG, then again we should know how to give oxygenation, discontinuation of any liver stimulant agent, change the maternal position, resolution of maternal hypotension, per vaginal examination to determine any cord prolapse or epicervical dilation, descent of fetal head, ARM, assessment of uterine contraction, tocolytics in tachycardia sleep with associated FHR changes. When the FHR tracing includes recurrent variable respiration, aminofusion sometimes can be tried. So this was all about the fetal monitoring, and I think I finished in time. Thank you very much.
Thank you, Bharati madam, for that wonderful talk on intrapartum surveillance. It is now the basis on us practicing obstetrics. And in today's era of litigations, it also stands as record for us if at all something goes wrong in spite of our careful care for the patient. And if you happen, you had given us 2 episodes where we had the babies were stillborn. In such cases, maybe the evidence, if we have now so many issues against the doctors. So it's such a thing, no, like it also stands as an evidence. And so it's a fetal surveillance is a must in our day-to-day practice. And madam, you have given us so many cases and so many examples. And it was really wonderful, madam. Thank you. Thank you for that talk.
Thank you, all of you, that you have given me opportunity. Thank you.
Madam, 1 minute, madam. Durgadas sir logged in. Sir, please tell about your words of wisdom, sir. Hello, Durgadas sir.
Yeah. At the outset, thank you everybody for giving me this opportunity. Dr. Bharti Maheshwari, it was a beautiful talk. While so many years back, Dr. Arul Kumaran was talking about fetal ECG, we were surprising. Can it be possible? Now it is in the textbook, and I don't know. Days may not be far off. It comes to a regular practice. Just now I am coming from a labor room. Sorry for the delay in joining because I had an outlet forceps delivery, and there is a reason. So, at the outset, this is a beautiful concept. The trio joining Dr. Radha Lakshmi, Dr. Shanta Maheshwari, and Dr. Vijaya, the southern states, they are joining hands. It's a beautiful concept of having a harmonious relationship of between one another. Thank you, madam, for giving me the opportunity to be here. I acknowledge the presence of Dr. Aruna Suman and Dr. Umayya Murugesh with due respects. My friend Dr. M.C. Patel and today's experts Dr. Venkataram and Ramarao and all the panelists, I acknowledge your presence. Coming to the concept, see, this is how the knowledge should be delivered. Like just yesterday, we had a webinar with in the same platform. Like though, of course, it was only within the state. That was a competition between the societies we have conducted, and the youngsters were coming on the platform, and they were giving wonderful talks. And by listening to Dr. Bharati Maheshwari, I was thinking so many latest concepts are coming up. Only through these webinars, we can update our knowledge. With these few words, my best wishes to Dr. Bharati Maheshwari, my dear Shanta Durge, Dr. Vijaya, and all the content. I think only three of us. Anybody else is contesting this time?
Radha Lakshmi, myself.
Radha,
Yeah.
madam.
Radha.
Yes.
Radha.
Yeah,
Aruna
we are
Suman.
all with you.
Aruna Suman and
Sir,
Dr.
Aruna
Umail, Dr.
Sir, I'm
Umail.
contesting for
We all are there, sir, and we need your blessings also.
Yes,
So why-
sure.
need your support.
Sir,
from
5
Karnataka,
members
sir.
from South, sir. 5 members from South in
Great,
this webinar.
great. I assure you, Kasoga is going to be with you. Definitely, we are all going to be with you.
Thank you, sir.
And I'm hoping to see you to come out with flying colors. All the five of you. Thank you.
Thank you, Dr. Durgadas.
Yes.
With your
Thank you,
support,
Dr. Durgadas.
Shanta madam is telling something. Shanta madam is telling something.
Shanta madam.
with your support, it will be really coming into the.
With madam, I'll tell you all the five. This is this thing. Kasoga is going to support you. Now Kasoga is so much active; it has come to the grassroots levels, and we can definitely pass on this message. We'll take it from me. We are going to be with our own people. Thank
Sir,
you.
we have
All the
got-
best.
we have
Thank
got
you
such
so
a
much, sir.
vibrant president
Sir,
of
we
Kasoga.
are going to conduct further the South Indian state webinars
Yeah.
again
Yeah.
in next weeks also. We
Yes.
want your blessings for
Yeah, I
that
will.
in the
Yes.
future also, sir.
Yeah. Yeah.
From Karnataka state.
Sure.
For all the 5 of us.
Yes. Yes. Yes.
And Bharti Maheshwari madam.
And
from
Bharati Maheshwari, I had shared the platform with her in one of the panels. If she remembers,
Yes.
I was 2 times. Even once I was the chief guest along with her. Anyhow, I don't waste time. All the best to everybody, and every program I will be with you.
Thank
And
you, sir.
Kasoga
Thank
is
you.
going to be with all the 6 of you,
Thank you so
not
much.
5,
Thank
6
you.
of you.
Thank you.
All the
Thank you.
best.
Thank you so much, sir. Thank you.
Now I request Shanta Durge to introduce experts of the panel. Dr. Venkatramana sir, President Kurnool, and C.V. Ramarao sir, President Srikakulam. Venkatramana sir. Shanta.
Thank you, Dr. Radha. I am introducing here Dr. Venkatramana, who is specially trained in laparoscopic surgeries, and his work experience is 25 years in Kurnool Medical College, Kurnool as assistant professor, associate professor, and HOD OBG, retired one. Presently working as professor OBG, Vishwa Bharati Medical College, Kurnool, and done more than 50,000 laparoscopic surgeries, and along with advanced laparoscopic surgery. The key responsibilities which he handled are KMC Alumni Ex-President, IMA Vice President, Member State Motherhood Committee Proxy 24 to 26, DIRA Awardee, and Best Doctor Awardee, President Kurnool OPG Society, and AP State Government Laparoscopic Trainer, Surgery Trainer. So, shall I move to Dr. V. Ramarao?
Sir,
He's the-
Vijaya, will you introduce Ramarao sir?
Yeah, of course, yeah. Sir, welcome, sir. Great. We are feeling great for your presence. Dr. Ramarao is an emeritus professor, Department of OBGYN, GEMS Medical College, Srikakulam, Andhra Pradesh. And he has done his UG and PG from Kurnool Medical College. And he worked from 81 to 2008 in Andhra Pradesh Medical and Health Department in various capacity. And he has worked in KIMS Medical College as professor at Amalapuram, NRA Medical College as HOD at Visakhapatnam, retired from GEMS Medical College as HOD of Srikakulam, and UG PG examiner from Karnataka, Telangana, Kolkata, and Rajiv Gandhi Medical University. He has several publications in national and international journal. At present, he is the president of Srikakulam OBGYN Society, and he is an emeritus professor OBGYN at GEMS Medical College. And area of interest is cancer service, NDVH. Very great, sir, and organization issues. Welcome, sir. Welcome you to this webinar, sir.
So now it is my proud privilege to introduce Patel sir. So everyone knows about Patel sir. He is a friendly nature and of down to earth, and he helps everyone in Foxy. And he want to uplift everyone in the Foxy. Thank you, sir. And he is the consultant obstetrician and gynecologist and medico-legal counselor, Vice President Foxy 2018, Organizing Secretary AACOG 2017, Chairperson Ethics and Medico-Legal Committee Foxy 2011 and 13, Honorary Secretary State Organization of Gynecologists and Obstetricians of Gujarat 2022 and 24, Organizing Chairperson of MMCon 2018, Honorary Member National Inspection Monitoring Committee PNDT Act Government of India, Honorary Member State Supervisory Board PNDT Committee Gujarat State, President Ahmedabad Obstetric and Gynec Society, and the National President National Medicos Organization, President IMA Ahmedabad Branch 2007 and 8, and a Honorary Surgeon Indian Red Cross Eye Bank. He collected more than 1,000 eye pairs. Organizing Chairperson Vivekanand MNO Con 2013, President Lions Club Ahmedabad 1997-1998. We welcome you, sir. Patel sir.
Yes, thank you, Radha, for kind words.
And I want to introduce the panelists also.
Yes.
Manjula Raghunandan, she is the presently the president of Nalgonda Obstetric Gynec Society, and previously she worked as secretary, vice president, joint secretary of Nalgonda Obstetric Gynec Society, and she is the medical director and senior consultant in Srinivasa Nursing Home, Nakrekal, Nalgonda. Our areas of interest are adolescent health education, anemia program, high-risk pregnancy management, cancer prevention, and menopausal health improvement, and conducted many CMEs. Welcome, Manjula. Hello, Manjula. Are you there? And I welcome Dr. Shailaja. She is the General Secretary, Nizamabad OBG Society, specialist in high-risk pregnancy and specialist in aesthetic gynecology. We welcome Shailaja. And Dr. Nissi Vinodna, she did her MBBS and MD from Kurnool Medical College, consultant at Medicure Hospitals, Anantapur, and Secretary, Anantapur Obstetric Gynec Society. Welcome, Vinodna. And Dr. Radhika Kurapati, she is Assistant Professor at Government Maternity Hospital, Kakatiya Medical College, Warangal, consultant at HOD Department of Obstetrics and Gynecology, Kurapati Laparoscopy Fertility Center, Warangal. Founder, Treasurer, Kurapati Foundation, Director, Safe Hands and Healthcare Private Limited. Welcome, Radhika. And Dr. Baby Shalini, she is the Consultant Managing Director at Shrestha Hospital and Secretary, Chittur Obstetric Gynec Society, Certificate Course in Contraception and GDM. And areas of interest are positive childbirth experience, childbirth education, PCOS, minimal access surgery. Welcome, Shalini. And Dr. Pandurangaya, he is the Assistant Professor, Chikmagalur Institute of Medical Sciences, presently the Secretary of Chikmagalur OBG Society, PC PNDT member, District Inspection and Monitoring Committee, MTP member of District Medical Board, trained in ultrasound, infertility and advanced gynec laparoscopy, Chair and Organizing Committee, AKCOG 2022. And more than 30 research articles published in national and international journals. Welcome, Dr. Pandurangaya. And Dr. Shushma, she is the Secretary of Chikballapur Society. She did her MBBS at KIMS Hubli, DZO at Hoskote, DNB at Bangalore, worked as Senior Resident at Akash Institute of Medical Sciences, and teaching experience 3 years, published papers in national journals, actively into private practice since 12 years. Welcome, Dr. Shushma.
Thank you, madam.
Now I request Patel sir to start the program.
Oh, yes. So please allow me to share my screen.
Yes, sir.
Okay.
Can the panelists switch on their videos?
Yes,
Yeah.
madam. Done, madam.
Only 1 minute. Is it seen full screen?
Yeah.
Yes.
Yes, sir.
Yes, sir.
Yes.
Yes, sir.
So it will be just brief in beginning, and then panelists will be allowed to ask question. Greetings from Statue of Unity, tallest statue of world. We all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank organizers and Dr. Radha Lakshmi and Dr.
Thank you, sir.
Santa Madam in particular for inviting me to share my views about the subject. And
Thank
before
you.
we start a panel, I wish all the contestants contesting for different posts in Foxy to have a great success in their respective committee. I again thank you all because you all were with me during my election campaign last year for Foxy. Of course, I lost, but I believe in this. It is nicely written by Shraddha Atal Bihari Vajpayee. क्या हार में क्या जीत में किंचित नहीं भयभीत में कर्तव्य के पथ पर जो भी मिला ये भी सही वो भी सही. So loss is not the end but a new beginning. Journey to serve Foxy continued with renewed patience. Thanks everybody for everything. So wherever you are, I will be there. Promise to reach the unreached. And today's topic, MTP Act and its amendment, what gynecologists should know. All the panelists already introduced and two experts, Dr. Venkataramana and Dr. Ramarao, will be with me as an expert to comment during panel discussion. Usually in my panel, I start with this. I never learn from someone who agreed with me. And if two people agree on everything, then one of them is not required. But today it is a different panel. It is reverse panel. Panelists are going to ask and I am going to answer. But this question I would like to ask all the panelists. Is it worth discussing MTP Act and its amendment? Is it worth discussing?
Because this panel
Yes.
50%
Yes, any panelist can take it.
Good evening, sir. Definitely, this requires discussion because the new amendments of 2024 that we have to inculcate in our day-to-day practice and be safe and even legally responsible for all the
Yes.
patients we attend.
Yes. So it is very important and it is a very important thing. Medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. And ignorance of law is no excuse, because as soon as any act, any law, any ordinance passes in government gazette, it is presumed by law that each and every citizen of India knows that law. So ignorance of law can never be an excuse.
Madam, myself, Dr.
And
Radha Lakshmi.
if you do not follow
Hello.
provision of MTP
Madam,
Act 1971, as far as abortion
please stay for
services
2
are concerned,
because
then you may be tried under
Radha
whole
Lakshmi, please
section
do.
of 312 to 316 of Indian Penal Code, and it is a criminal offense. So we should be very careful whenever we are offering our abortion services to our patient. So let us start with case. Any panelist can take any case, any question. I am here to answer.
Hello, good evening, sir. I am Dr. Radhika from Warangal Obstetric
Yes.
Gynec Society.
Yes, welcome,
Hello.
madam.
Sir, I have a question. A 14-year old girl brought by her mother to a family physician with the complaint of pain abdomen and lump in the abdomen. After giving primary treatment, the family physician referred her to surgeon. The surgeon refers us to a sonologist for sonography. Comes with a report of 18 weeks pregnancy. Mother wants termination of pregnancy. How will you manage?
So she is 14, so she is minor, and she is 18 weeks pregnant. So it becomes a case of POXO. So even if you terminate, if you do not terminate, but once you came to know that she is pregnant and she is minor, you have to inform police. Of course, you can terminate pregnancy if your center is registered, if you are qualified, then you can very well terminate that very pregnancy. But before that, you have to inform police. And after this termination, you have to preserve product of conception in normal saline, and it is to be handed over to the police.
Sir, is it necessary to report to district health officers, DM and HO?
No. As far as provisions of PCP, this MTP Act is concerned, in this case of it is mine also, we have to inform police. Otherwise, we have not to inform anybody. Because under POXO Act, under section 19, it is mentioned, being a responsible citizen of India, once you come to know that she is victim of sexual offense under POXO Act, you have to inform police or CWC, that is Child Welfare Committee. So either of two you can inform, and you are out of your duty.
Sir, can I ask one question?
Oh, yes.
See, sir, when we are going to inform the police, usually the patient won't like and they leave our hospital. In such case, even if the patient left our hospital, are we supposed to inform the police?
Yes, because once you came to know that she is minor and she is pregnant, so she is a case of POXO. So irrespective whether patient continue treatment with you or not, doesn't matter, but you have to inform police.
Thank you. Thank you, sir.
And whenever you inform police, you have to inform with acknowledgement. Because if at all you have to face this case in court of law, then you will have to prove that you had informed police. Because many a time police may go hostile, that you never inform, you didn't inform. So you will have to prove. So whenever you inform police, say for example, if you have sent a letter, then you have to send 2 copies, and 1 copy is to be signed by police station officer who has received that very letter. But many a time you will experience that police are not ready to give signature on that very letter. So in this situation, there are some options. Same letter you can send it by registered AD post, you can send it by mail, you can send it by calling number 100, because number 100 is a recording call. So whenever you give any information on number 100, it will be recorded. But in this situation, you will identify the person whom you are giving information, name of that very police officer, buckle number, date and time. It is very important, and it is to be recorded in your record whom you have informed. You can inform from your mobile also to a police station officer of respective police station in your area. But if you have recording in your mobile, again you will confirm whom you are informing the case. So these are some ways. One more area, if lower police officer is not complying, then you can inform higher police officer also. And at last, you can inform member of CWC. Once you have informed member of CWC, that is Child Welfare Committee, your job is over.
Sir, I have a doubt, sir. Dr. Vijay from Chennai, sir.
Yes, madam.
If the girl is around 12 to 14 weeks and she is bleeding, and I don't have time to inform the police, can I start the treatment and later inform the police, sir?
Naturally, yes. Because first duty is to treat patient. Because in very famous case of Parmanand Katara, Supreme Court has very specifically mentioned, first you treat patient whenever it is an emergency, all the formalities after. But at the same time, word of caution, before patient leaves your premises, you should inform. Why? Because say for example, she is bleeding. You have managed the case accordingly, say for example, evacuation or whatever. And you have preserved product of conception, it's also fine. But before you inform police, if by any source police comes to know that she is victim of sexual offense and she had been treated by you, and police will come to you, why you didn't inform police? Of course, you will explain that it was an emergency. First, my role was to treat that very patient, so I was busy with my treatment. But just you are out of your this treatment part and you are free before patient leaves your premises, it is always better to inform police.
Sir, Dr. Aruna Suman sir, good evening.
Yes, madam. Welcome. Welcome.
Sir, actually, many unmarried girls who are 16, below 18 years, they come to us. And the pregnancy is 28 to 30 weeks. So what is the role of, sir?
Yes. So in this case, in POCSO Act, age matters, marital status doesn't. So irrespective whether she is married or unmarried, when she is minor and when she is victim of sexual offense, that is she is pregnant, then you have to inform police. As far as size of pregnancy is concerned, if that very pregnancy is up to 20 weeks, you can terminate pregnancy with opinion of one registered medical practitioner. If pregnancy is more than 20 weeks and less than 24 weeks, and she is victim of sexual offense, so it becomes an indication for termination. So you can terminate pregnancy with opinion of two registered medical practitioners. If pregnancy is more than 24 weeks, then you have to refer to medical board. But in this situation, if pregnancy is very normal, even if she is minor, pregnancy is more than 24 weeks, and pregnancy is normal, medical board has no power to opine. So medical board can only opine in case of congenital fetal malformation, substantial malformation, or it is called incompatible with life of fetus. Then only medical board can opine to terminate pregnancy. In all other cases, even if she is minor, she is victim, and pregnancy is more than 24 weeks and normal pregnancy, one will have to rush to Honorable High Court seeking writ petition for permission of termination of pregnancy.
A registered medical practitioner.
Myself,
Sir?
Radha Lakshmi.
Yes, one by one, yes.
So one patient came to family planning department in a government medical college saying that she is para 2 L2, not tubectomized. Husband died and she wants to go to Dubai and she wants to undergo sterilization. Can we do sterilization for that patient?
She is widow.
Yes, sir.
So as such, what is the purpose of sterilization? What is the indication? If
She wants to go
get
to
married?
No,
again?
no, sir. She is going to Dubai and she wants to undergo sterilization. That
But
type
there
of
should be
cases
some
we get
indication,
in
na?
government service many a time, sir.
Agreed, but whenever we do any surgery or any treatment, there should be some indication. So what will be the indication in that very patient for sterilization? Willingness on part of patient?
Yes, sir.
So could it be indication?
No, sir. No, sir.
So, sir, she is widow, but she wants to undergo sterilization.
Oh, she should be ever married. No, for sterilization, they should be ever married.
Agreed, she should be ever married, having one child at least of 1 year of age. These are some criteria, and age is also one criteria. But in this case, when she is widow and she is going to go for sterilization as she is going for Dubai. So as such, we can. Legally, it cannot be challenged because when she is major, when she is mentally sound, she can take decision and we can. But what indication would you like to write? That is my question.
Sir?
We did sterilization in that case because our superintendent insisted to do tubectomy for that.
No, legally we can. When she is major and when she is mentally sound, she can take decision. So we can. Legally, it cannot be challenged. But as far as our, this is matter of discussion only. What indication we will write for tubal
Is the marital status a compulsory indication for the sterilization?
Pardon?
Marital
Is
status.
the marital status of the person?
No,
Is the compulsory?
as said not. In government, this manual, they have written patient ever married.
Yes, sir.
So ever married means married but widow, married but divorcee. So it could be.
Not ever married.
So she is a major and mentally normal.
Sound is the, but this is enough.
Okay.
It is enough. She is major, she is mentally sound, she can take decision, she can give consent. All other relatives are witnesses only. Nobody else can give consent on her behalf. She is ready to give consent on her behalf. So you can very well proceed.
Sir, what is the maximum age limit, sir, for to undergo tubectomy?
49.
45 or 49?
49.
49 for female. Male, sir? Male also same.
Exactly, I have no idea. But in government manual, as far as female party is concerned, it is 49.
22 to 49. Sir.
So one more case, sir.
Yes.
So the patient is para 2 L2. She has given consent to undergo tubectomy. One gynecologist did a tubectomy. After some time, her husband came and put a case on the gynecologist telling that her wife underwent tubectomy without his knowledge. So how to proceed in that case, sir?
There are two views in this type of situation. In one of the cases, Supreme Court has given an instruction that when you are going to put full stop on her reproductive capacity, of course, tubal ligation may go fail, but as it was discussed like this. So husband should be taken into consideration and consent of husband should be taken. It was observation on part of Supreme Court. But at the same time, there are so many states in India and in respective state, there is a circular on part of government that signature of husband is not required, consent of husband is not required as far as sterilization operation is concerned. So state where you are practicing, in that very state, if it government circular that signature of husband is not required, then you can very well go with sterilization, female sterilization, and husband signature is not required. So in that very situation, you are safe.
So in the National Family Welfare Guidelines also, there is no need to take, you have to inform the husband, no need to take any written signature. The mother.
But there are circular in all respective state. So you go with that manual also and that circular also. So you are safe legally.
Sir, this is Dr. Panduranga, sir.
Yes, welcome, sir.
So the same thing, for sterilization, husband consent is not needed. What about the MTP, sir?
MTP also, husband signature is not required. Because in MTP, it is very clearly mentioned that patient herself will give consent when she is major and mentally sound. If she is minor, then consent of guardian will be required. But again, in this case, just we discussed prior, it becomes a case of POCSO and we will inform police.
Yes, sir. Yes.
Hello, sir. Can a medical practitioner who has a clinic prescribe mifepristone, sir?
Yes. So if he is running only clinic, only OPD, and he has no indoor, he can prescribe MTP pill, but condition, he should have access to any registered center. When if at all any complications happens, care can be taken for that very patient. And certificate of certificate on part of that hospital where he is attached, that certificate he will have to display in his waiting room where he is running her OPD. So if he is attached with clinic, and he has put certificate in waiting room, then he can prescribe MTP pill.
Thank you, sir.
Sir, for the MTP, sir, about the consent, whether it is taken as usual manner or how we want to take the consent, sir?
No, it is very much compulsory to take consent in Form C. It is prescribed form. But
Yes.
in Form C, it is a very simple consent. I give my consent to terminate my pregnancy. So it is not informed consent. So when you are going to go for termination,
Sir, you are not audible, sir. Now audible.
Yes, sir.
Yes. So whenever we are going to deal with any case of MTP, it is very much compulsory to take consent in Form C. It is mandatory. But if that very Form C is not consent, informed consent, because it is very simple. I give my consent to terminate my pregnancy. That is written in Form C. So we will have to go with two consent. One informed consent, as we take in usual manner in any other surgery or procedure, and one in Form C. Whether we are going to terminate pregnancy by medical method or by surgical method. So we will go with two consent. And for that, you have to simply visit Foxy website. On Foxy website with uniform Foxy uniform consent, we have prepared 30 different consent.
Yes.
I, Dr. M.C. Patel, Dr. Dilip Walke from Pune and Dr. Nikhil Datar from Mumbai, with 3 medical legal experts have prepared all those consent. And in those consent, we have prepared consent for termination of pregnancy also. So it is available by medical method and by surgical method. Both consent are available. You have to simply download and use in your day-to-day practice.
Okay, sir. Thank you. Whatever that Form C, that C is there, no, sir. That is the same thing.
Form C is very much compulsory. Why? If you have not taken consent in Form C and you have terminated pregnancy, even your center is registered, even you are qualified, then also investigating officer may put you in trouble because you may be tried with Section 313 of Indian Penal Code. That is termination of pregnancy without consent. And there is a provision of imprisonment of 10 years. And we cannot afford that. And that is why in any case of termination of pregnancy, we have to take consent in Form C.
Okay. Sir, one more thing. This is from this one. Sir, what about whether we can refuse the MTP, sir, when patient has come?
Yes. So very important question. Is MTP right of patient? So no, it is not right of patient. There should be some indication as prescribed in MTP Act 1971. If there is no indication as prescribed in MTP Act, then you can very well refuse patient for termination of pregnancy. Because in one of the cases, Supreme Court has very specifically mentioned that it is not right of patient, it is not MTP on privilege of doctor to decide. There should be some indication and then only you can terminate pregnancy.
So most of the patients tell that it is because of failure of contraception only, sir.
Yes.
So maybe it may be because they might have undergone sex determination somewhere else, and it is less than 20 weeks. They are telling that we don't want to continue the pregnancy, please terminate. Then
Yes.
how to tackle that case?
Yes. Let us see the same type of case and we will discuss that. 26 years old patient, G3P2L2 having 22 weeks pregnancy for termination of pregnancy and reason given failure of contraception. RMP did MTP. Later both women and doctor were arrested. 26 years old, 22 weeks of pregnancy. So indication failure of contraception is not available beyond 20 weeks of pregnancy. So if pregnancy is less than 20 weeks, then termination of pregnancy with indication of failure of contraception it is available. But if pregnancy is more than 20 weeks, then you cannot terminate pregnancy on that very ground. One more situation, just you told. If patient is having pregnancy nearby 11 to 13 weeks, and patient comes to us, and during history, if we come to know that she is having one female child or more than one female children, then we should suspect that that group of patient, because these are vulnerable group of patient. It is all likely that she might have gone somewhere and have got sex determined, and she had come to us telling that it was failure of contraception and she doesn't want pregnancy to continue. But in this situation, we have to inquire that way, that if it was failure of contraception till this 12 weeks of pregnancy or 13 weeks of pregnancy, why you waited? Indication was clear. If it was failure of contraception, if you were not willing to continue pregnancy, then why you waited for 12-13 weeks of pregnancy? Many a time during this conversation, we can come to know that patient is has gone somewhere. But it is always better to refer this type of patient to government hospital. In private hospital, not to take risk.
Okay, sir. So one patient, one unmarried girl, aged about 13 years, in 8th class, she came to OPD and she is about 16 weeks pregnant. The cause for the pregnancy is her own brother. And I wanted to inform the police people on the same day, and the patient and that victim girl along with the parents, again she absconded, sir. So in such a situation, is it necessary for me to inform police people or not?
Yes, it is very much compulsory. Under section 90, just I mentioned prior also. In that very section, it is very specifically mentioned that being a responsible citizen of India, irrespective of whether you are a doctor, even
So
any lay people,
parents are not
willingness on part of
willing.
patient relative
No.
is not required. Willingness on part of patient not required. So irrespective that, so you have to inform police. Whether police will take action, what police will do, that is up to police. But once you inform police, you are safe. Because again, under section 21 of POCSO, if you fail to inform, then there is a provision of 6 months of imprisonment and fine of some rupees. So we cannot afford that, and that is why, irrespective of anything, once we come to know patient is minor, patient is pregnant, so she is a victim of sexual offense and it becomes a case of POCSO, we have to inform police.
Can we refuse that case?
Pardon?
Sir, can we refer the case to government hospital?
Of course, you can refer that very patient
Without
anywhere,
informing
government, etc. But again, you will have to inform police.
Without informing, you should not refer.
No. You can refer, but at the same time, you will inform police. Patient name so and so, aged so and so, residing at had been to me, and during my
If the patient fails to give their Aadhaar card and address
yes, we will have to confirm. Whenever you are dealing with minor patient, always insist for Aadhaar card.
If they fail to give,
it is likely that they give false information.
Sir, if they refuse to give their information and address,
then also we have to inform police that patient was not willing to give Aadhaar card. She has given this name, whether it is correct or not, I do not know, but I am informing you. Once you inform, your role is over. It is matter of police to investigate that very patient, whether patient has given you true information or wrong information. But usually, when patient is not knowing that in case of minor, it becomes a case of POCSO and doctor will inform police, it is all likely in majority of the cases, they will give right information as far as name, address, etc. is concerned.
Can we refuse also, sir, to do
yes,
that?
We can refuse, but we will have to inform police.
Okay. Vinutna, do you want to ask any question? Vinutna? Unmute. Unmute, Vinutna.
Sir, I have a question.
Yes.
Suppose if the patient is a student or a nursing staff known to us, just cross 20 weeks, can we just put 20 and do the things just to help them out?
What is the age of patient? It is very important part.
Age.
If she is major, then there is no problem because she can give consent for termination of pregnancy. And if you write pregnancy is less than 20 weeks, then there should be some indication. If it is more than 20 weeks, say for example, and even if you have indication up to 24 weeks of pregnancy, you can very well terminate pregnancy with opinion of 2 registered medical practitioners.
Yes, sir.
Vinutna?
There are some 7 indications given in MTP Act in amendment after 20 weeks and less than 24 weeks. So if any of indication is available, then you can very well terminate up to 24 weeks of pregnancy.
So can I ask a question, sir?
Oh yes. Oh yes.
Radha, I'll ask.
Yeah.
Sir, actually nowadays I'm seeing the patient's name, the age is less than 18 years, 17 years, married, coming with the husband, and the mother-in-law and the girl side both are coming, and we ask for the Aadhaar card. Then usually they say 18 years. When they say 18 years, I always ask for the Aadhaar card. Most of the time it is only 17 or 16, it is not 18. Then how do we go about that, sir? Because both are happy. No, there is no complaint there.
Agreed. Same we have to inform police. But in one of the cases in Supreme Court has an observation that if they are happily married couple, even though they are minor, and they have no problem in their marriage life, why doctors should inform police and why police should investigate that very case and why police has to harass this couple? This was the very important questions on part of Supreme Court.
But that is not a legal age, no, sir. 18 is.
Let me complete. Then we will discuss. So Supreme Court has observation that if they have married for more than 1 year, even if they are minor, and if doctor has informed, doctor will not be held responsible. But I am waiting for that judgment and exact wording because it has come in recent past only. So exact wording on part of Supreme Court. If Supreme Court has very specifically mentioned that if it is more than 1 year of marriage life, and even if they are minor, and doctor need not to inform, then with this we have to approach central government to come with clear-cut guideline. In this type of situation, if doctor fails to inform, then doctor will not be held responsible.
But as of now, we have to inform.
Yes, as of now, we should.
Sir, lastly, you spoke about the amendments of 2024. In that one amendment is failure of contraception for doing MTP in between 20 to 24 weeks. She can't tell all one of the
no, madam. The failure of contraception is available up to 20 weeks only.
Okay. In that on the 7, one is vulnerable woman by rape, incest, and all, or any
that is different story. Let me complete. If she is rape victim, then that very indication is available up to 24 weeks of pregnancy.
In that 7 thing, failed contraception is also one.
But why we have to go for that indication? When she is victim of rape, when she is minor.
No, sir. Both different.
Up to 24 weeks it is available.
For rape, yes, sir. For failed contraception.
So let us discuss that also. If pregnancy is more than 20 weeks and it is less than 24 weeks, there are 7 indications. And one indication is minor, rape victim, change of marital status. Say, for example, during ongoing pregnancy, death of husband or divorce, then this indication is also available for termination of pregnancy up to 24 weeks of pregnancy with opinion of 2 registered medical practitioners. Physical disability. If patient is handicapped and if she falls in list given in Indian Handicap Act, so if that disability is there, then that becomes indication to terminate pregnancy up to 24 weeks of pregnancy. Congenital fetal anomalies which are incompatible with life of fetus, then also it becomes a indication. Mental retardation. When patient is mentally retarded, then also you can very well terminate pregnancy up to 24 weeks. But in this situation, I would suggest to have certificate from psychiatrist that patient is mentally retarded and you are going to terminate pregnancy. And last indication given is on humanitarian ground. So say for example, in era of COVID-19, there was instruction on part of government that there should be minimum visit of patient to the hospital. So in this type of situation, the patient has failed to report, and when patient comes to you and pregnancy is more than 20 weeks and less than 24 weeks, and if there is notification on part of government, you can very well terminate pregnancy with opinion of 2 registered medical practitioners.
Okay.
So these 7 indications are available up to 24 weeks of pregnancy.
Done, sir. Thank you.
Sir, I have one question, sir.
Yes, welcome.
Sir, a 21-year-old primary gravida, 26-week pregnancy, brought to a nursing home with history of fall and found to be abruptio placenta. And doctor said she'll need urgent surgery and termination of pregnancy, but will need broad approval and also must be done in medical college. So she was referred to a medical college. Is it a right advice or can we proceed, sir?
No, it is not right advice, because irrespective of gestational age, when she was bleeding or she was diagnosed as a case of abruptio placentae, and if it was immediate necessary to terminate pregnancy, then one has to terminate pregnancy in this situation. Here, no purview of MTP comes, because under section 5 of MTP Act, you are allowed to terminate this type of pregnancy even at unregistered place. Even place is not registered, then also you can terminate pregnancy if it is a case of abruptio or if it is severely bleeding and you have to terminate pregnancy, you can very well terminate.
Yes,
So to take opinion from medical board, this pregnancy can only be terminated at government hospital. These are not right approach. Anybody can terminate pregnancy at any place. Person should be qualified to terminate or to deal with this type of situation, because it is a complication of pregnancy, and complication of pregnancy doesn't come in purview of MTP Act. No need to go for any form C, opinion form, nothing. You simply have to terminate pregnancy in this type of situation if it is medically indicated.
Okay, sir. Thank you, sir.
So where are the consent forms available, sir? In FOXI website?
FOXI website, you have to go for FOXI uniform consent and you will get it. Or you can approach me, I will send you. It
This
is
form
available.
number C1, 2, 3.
Form, this is also on website. MTP Act forms, you will get all the forms. So it is available as far as this uniform consent on FOXI is concerned. It is available in English, in Kannada, in Marathi, and now Gujarati version is also ready, and we are going to release that also. So if any society of
This
Andhra
is
Pradesh,
the so display of that registration of MTP and tubectomy should be done in each and every nursing home setup.
Yes. In waiting area, we should display certificate of MTP, that is Form B. We have to, and as far as PCPND also, we have to display. It is compulsory by law, and as such, all our degree in our consulting room should also be displayed as per guideline from MCI.
Sir, one question.
Yes.
This is not related to MTP, but with sterilization. If the marital status of the woman is compulsory, if an unmarried woman asks for the sterilization, what the doctor should do?
No, in that very, they have written married or ever married. So in this situation, you cannot. If it is indicated medically for some medical reason, then it's a different story. But otherwise, not.
So we have to reject them.
Yes, naturally.
So any other question? Dr. Shailaja, are you there? Shalini?
I have a question, madam. I'm Dr.
Yes,
Radhika.
welcome.
If an unmarried girl takes a MTP kit by her own outside the hospital and comes to a doctor for consultation, if he found any retained products of conception, is it necessary to inform to the police?
No. If she is minor, then yes. Because if she is minor and it is product of conception, it means she was pregnant and she is minor, it becomes a case of POXO. If she is major, then it is a complication. You have to treat as you treat any complication. In this type of situation, it doesn't come in purview of MTP Act.
Okay, sir.
So, is there any question? Should I ask very interesting situation I can discuss?
Okay, sir.
Okay. So, your place is approved. You are qualified. Pregnancy is less than 12 weeks. Patient is major but unmarried. My question, can one terminate pregnancy? Yes, no.
Yes, sir.
Yes, yes,
Yes.
Yes.
If it is yes, then should one inform police?
No need, sir.
No. Major, no.
Major, so no. But in this situation, the same situation which happened in state of Gujarat only, pregnancy was terminated because center was registered. Person, our gynecologist friend was qualified. Pregnancy was less than 12 weeks, and patient had been with her boyfriend, and signature of patient was taken as a concern because she was major. After 1 month, police came, and police said to that gynecologist, she has lodged complaint against that very boy for charge of rape because he has given promise of marriage, and against promise of marriage she has given consent for coitus. So, and now he has declined to get married. So, it becomes a case of rape. Why you didn't inform police was the question to our female gynecologist from South Gujarat. She consulted me, we were out of problem, but this type of situation may occur. So not to end up into this type of situation.
So how does doctor knows whether the pregnancy is because of boyfriend or because of his her husband? She came for MTP and she is a major and she's married.
Unmarried. She is unmarried. She is major. So marital status doesn't come. So in this situation, my question, any special precaution would you like to take at the time of dealing this type of situation? You can very well terminate pregnancy because your center is approved. You are qualified. Patient is major. But
So
any special
better to
precaution?
take the consent from the parents of the patient.
No, because you cannot disclose personal privacy of patient when patient is major.
The written consent from the patient.
In this type of situation, patient will sue you.
They
That
take
doctor
the-
disclose my personal information to my parents.
A consent
You
from
cannot.
the patient herself, sir. Because she's a major, that consent is valid. Written consent from the patient.
That everyone takes, no?
Yes.
Sir,
But
in
you
our
don't have. Let us conclude. In this type of situation, this 3 sentence will be very much important. She will give in writing, her own writing, fine. Otherwise, you can write and she may sign. It is a result of consensual sex. So at that point of time, when you are examining that very patient or you are going to terminate that very pregnancy, it was result of consensual sex. no complaints against anybody. At that point of time, she had no complaint against anybody. And I do not want to inform police. So at that point of time, doctor is very clear that it is a result of consensual sex. She has no complaint against anybody and she do not want to inform police. So how doctor can predict that in future there could be some quarrel in between and she may lodge complaint and she may lodge complaint of rape. So if you have taken consent like this with these 3 lines in case of unmarried patient, even if she is major, then you are safe, because in this situation police or even no court can harass you in this type of situation.
Sir, one more question, sir.
Yes.
One time when I was assistant in government hospital in Kurnool, so unmarried patient came and we informed police, and after the consent of parents, we did medical termination of pregnancy, 2nd trimester. After that, that patient and we failed to give the products of conception to the parents. Parents and also not given to the police. And after that, the patient went and started doing dharna in front of police station that the doctors wantedly thrown away the products of conception, like that she did. So what precautions we have to take in such cases, sir?
Was she minor?
Yes, sir. She is minor.
So she was minor, though under POCSO, you are under obligation to inform police and to preserve product of conception in normal saline, and it is to be handed over to police.
Okay, sir. We informed the police, but we failed to hand over that products of conception.
So, whenever you inform police, you should inform like this. This is to inform you that patient so and so, aged so and so, residing at had been to me, and during my examination, she was found to be 12 weeks or 13 weeks or 8 weeks pregnant. I am going to terminate her pregnancy at on. Please send your representative to collect product of conception. If patient doesn't turn up, if police fails to collect product of conception, you are out of problem, because once you have inform with acknowledgement, once you have informed, then you are out of problem.
So one last doubt, sir. One unmarried girl again came and she wanted to have MTP. She told that she want to with the consent of parents, and after the termination she wanted the products of conception so that she can sue against her boyfriend.
Is he medical legal, sir?
Again question.
Yes,
what
sir.
was the age of patient?
Again, she is a minor, sir. 17 years.
When she is minor, naturally you
So
have to inform police and you have to hand it over to police. But if she is insisting that product of conception is to be handed over to her, once you have informed police, then you will have to wait till police to come. Okay. And then naturally
it should be handed over to police people only.
Police will take custody. Yes, if she is major, then we have not to inform police. And if she demands that she demands that product of conception is to be handed over to her, you have to, because it is her right, because she is major, she can take decision whether he has to sue against that very person or so. That is her lookout, that is her prerogative.
Okay, we can handle. Okay. And if they issue a case and we must give the evidence in the court also, no, they will call again for us to come and attend the court to give the evidence that so and so person terminated the pregnancy and handed over the products of conception to that major girl, like that.
So whenever you are dealing with this type of cases, your documentation should be very
In such case, we can also refuse the MTP also, no?
You can refuse, but you will have to inform police.
Sir, if she is a major,
no, then no. If she is major, no. MTP is not an emergency, so you can refuse, no issue. Because many of our doctors on religious ground, they do not practice termination of pregnancy. Naturally, they refuse.
So, Dr. Shailaja?
Yes, sir. Good evening, sir.
Yes, good evening. Welcome.
Sir, today's problem that I faced today, 14-year girl, she came with 16 weeks pregnancy. With so much difficulty, I convinced her, made her sit in a room, informed the police. By the time police came, the girl ran away. The mother was in the hospital. Today, sir, even now just the police went, so I joined the panel. I gave them all the details. The girl
Yes.
ran away. Sir, it's literally when facing the situation to convince them to go to the police is one part, and if the girl ran away, what to do? So
Nothing can
it
be done,
just
madam. What
happened
is
now, sir.
No. Our
Just happened now.
our
job is
duty
over.
only to inform police.
Yes, sir.
We have not to,
I just did that, sir. They took
we
the
have not to
details from the
run behind
mother.
that very patient if patient absconds.
So
So
the
we
girl
have to inform
absconded.
police, and once you inform police, you are out of problem.
Yes, sir. I did that job, sir. That's why it was a delay. I missed this beautiful session. I was thinking if I had listened to this session earlier, I would have been more confident and
No,
more
no. But
vigilant.
whenever you are in a little doubt,
Patel sir, do
I
like
am always available. You can have a phone call to me at any given time. I will be there to guide you.
Thank you so much, sir. Sir, what is the role of spouse in the MTP and sterilization? Do we need the signature of spouse for MTP and for
This
sterilization?
question was taken prior also.
Yes,
As
sir.
far as MTP part is concerned, when she is major, mentally sound, no consent of husband or spouse is required. She can
Okay.
give consent. As far as sterilization part is concerned, it is better to take a consent of husband, but it is not compulsory.
Sir,
Because
husband in Dubai, they will call and say on the phone.
I am coming to it. Under government manual, and if there is a circular on part of respective state government that consent of husband is not required, you can very well go with termination of, female sterilization operation. But as far as social part is concerned, it is always better to take husband in confidence. Say, for example, husband is at Dubai and patient has come to you and she is willing to go for female sterilization operation, then you can talk to her husband on telephone, and if he is willing, fine. Or to be on safer side, if at all you apprehend that there could be some problem, then you can ask for consent from there also. He can go to notary, he can notarize his consent that I have no objection if my wife is willing to go for sterilization operation, then you are very much safe. But as far as legal part is concerned, even if you have not taken consent of husband, you are safe.
Okay, sir. Right, sir. Thank you so much, sir.
So thank you, sir. Dr. Ramarao, sir, your concluding remarks. Ramarao, sir, please unmute. Please unmute, sir. Okay, sir.
Very good. It's a very good session. The medical legal aspect, Hello, am I audible to you?
Yes, sir.
Yes, sir. You are audible.
Most of the doctors, they are not getting the DMHO certificate for conducting medical legal cases. They think that because I am a gynecologist, I need not have. Second thing is, the center must be noted, and the DMHO will see all the amenities are there or not. If as per the MTP Act, if the things are not clear and certificate is not there, even though he is a qualified gynecologist, if he does the MTP, it will become illegal and it will become a monster septic abortion. That is important thing.
Let me clear. If center is not registered.
Yes, I
am clarifying. If center is not registered, even person is qualified, then also he cannot terminate pregnancy at unregistered.
Yes. That is I am telling, sir.
One thing. Second situation. Center is registered, but person is not qualified. Then also patient should not be. And in both the situation, there is a provision of imprisonment of 2 years, which may extend up to 7 years, and fine, or both. So person should be qualified, center should be registered. So to conclude, let us have a final word from each panelist as a carry home message. Final word from panelists, one by one.
Sir, Venkatramana sir want to tell. Sir.
Yes, welcome, welcome, sir.
Sir, good evening, sir.
Good evening.
Yes, sir, if you are there, everything will be clear regarding the MTP Act, whatever the legal procedures. So that is a guidelines to all the budding gynecologists, sir. So as you told that MTP, every center should be registered under DMA. So then only, even if you are qualified also, you can do it, sir. So very nice word, sir. Thank you, sir. Sir,
Thank
kindly
you,
help the all the 6 members to get
I
elected
am
from the
always there.
South, sir. Yes, sir.
And
Thank you, sir.
You can ask any of your contestant how I
Yes,
am
sir.
helping and
Yes, sir.
how
Yes,
I
sir.
am
Yes, sir.
helping.
We know. I know personally you, sir. No problem. We became both friends, sir. Even though you are senior most, we are friendly, sir. Thank you, sir.
Dr. Patel sir has been so helpful. Whenever we call him at any part of the day, if he's not replying, no, he will call back after 1 hour or 2 hours. He'll say, "I did."
Of course, it is
missed
a
your
little
call.
early.
What's the
little
matter?
early, but same. I will request you all to reciprocate next year in
Definitely, sir.
2026.
Definitely, sir.
I am
Definitely.
going to contest
100%.
for President Foxy again, and you all will be with me. I am damn sure.
Definitely, sir.
Yes, sir. Definitely, sir.
Best wishes, sir.
Yes.
If as Professor Arul Kumaran sir has told, if a gynecologist or a registered medical practitioner does not support legal abortions, legal MTPs, then he is for illegal abortion. So we should always put effort to go for legal MTPs.
No.
Always.
As far as registered medical practitioner under MCI Act and now NMC, if he is registered under MCI, he can terminate pregnancy up to certain weeks as per he has taken this training. Say, for example, if he has taken training under government institution for 25 MTP, and if he has done 5 MTP under observation in government hospital, then even MBBS doctor can terminate pregnancy up to 12 weeks of pregnancy. And in this amendment which came in 2022, in this situation, even if he is MBBS, he can terminate pregnancy up to 10 weeks by medical method, medical pills. It is also in amendment if he has been trained under experienced person in government hospital. So MBBS can doctor also terminate pregnancy up to this gestational age, but more than 12 weeks they are not allowed.
Sir, one thing, sir.
Yes.
Latest amendment, up to 24 weeks we can do, provided that the government has maintained that they should have a state body, district body, and the body should be notified. But such things are not happened practically in our state, in Andhra.
No, agreed. So let me discuss that also. If pregnancy is more than 24 weeks, then we have to go for opinion from medical board. What is medical board? Medical board is comprising of one gynecologist, one pediatrician, and one sonologist. And government may invite 2-3 more people from private also. And when this act amended, it was mentioned on part of government that each district should have medical board.
Yes,
in so many districts, medical boards are already formed, and you will be happy to know that many of our gynecologist friends practicing in private, they are also invited to be member of medical board. So it is good sign. If in your district where you practice or where you work, medical board is not there, then on part of your association, which society,
What I wanted to tell is that only,
so,
sir.
So your society should approach appropriate authority to form medical board.
The society must take initiative in asking the DMHO to form the society. That is the correct way. Because if the government is not active.
Once medical board is formed, once any case had been to a medical board, medical board is also under obligation to opine within 3 days. Once any case comes to medical board, and if case is eligible to terminate pregnancy, for example, it is congenital fetal anomaly, which are incompatible with life of fetus, medical board will confirm by sonography reports, etc. And medical board will have to give opinion within 3 days. And when medical board opines, then that very pregnancy should be terminated within 5 days. So these two good amendment came in 2022.
Yes,
which was good faith of patient. Because
Yes,
it was very, because in past what happened, whenever opinion from Honorable High Court was asked to terminate pregnancy, Honorable High Court was referring patient to medical board, and there was no time limit fixed. So in one of the cases happened, which was published in newspaper Hindu also, opinion from Honorable Court was from medical board asked at 24 weeks of pregnancy, and when opinion came, pregnancy was 36 weeks. So not to happen this type of situation again, during amendment, government was very keen, and this amendment came that medical board will opine within 3 days and pregnancy will be terminated within 5 days.
Thank you, sir. Thank you for the wonderful session.
Yes.
And,
So let me complete with my, I ask for carry home message from each panelist one by one, if they are willing and if they are present. Or I may conclude and then you can conclude.
no problem, sir.
The consent in handwriting,
Yes, will do. In
uh,
handwriting,
take home
in,
message.
in type, even video consent is also good. No issue.
Okay, sir.
So to conclude, this gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know to how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. Because in spite of all these professional and occupational hazards, our journey to serve human and mankind is always on and on. So I conclude my talk or my panel with this. If you want to sleep like this, take tender care of your patient, comply with the provision of law, pray Almighty God before going to sleep, and keep my visiting card below your pillow. And this is law of leopard behind innocent gynecologist, and see the role of medical legal counselor, how he can be useful. So please do not hesitate and have a phone call to medical legal expert in any given situation. He is always there to guide you. So all the best. With regards, salute to organizers. Thank you very much. If at all there is question, I am here to answer. So please do not assume. Please ask if time and chairperson permits. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you so much, sir.
We'll ask you, sir.
Oh, yes.
Thank you so much.
We need your blessings from Gujarat and throughout India.
Yes.
Sir,
Yes,
I'll
we have-
circulate your number to all Telangana doctors.
Not from Gujarat only. I can influence outside Gujarat also.
Definitely. Thank you so much, sir.
Yes.
Thank you so much from all the 5 of us, sir. From
Yes.
South India, myself, Dr. Vijaya, Shanta Durge, Umayal Murugesan, and Aruna Suman. From North, Dr. Bharti Maheshwari. We need your blessings and support all the
Yes.
time, sir.
And one Jaya, you forgot. Jaya
Jaya.
is also there.
What, sir?
Shanta,
Jaya is also
sir.
contesting.
Shanta Durge, sir. Not Jaya.
Santa Durge madam is there. Umayal,
Umayal, Vijaya.
Radha,
Vijaya.
Aruna Suman,
Yes, sir.
and
Vijaya, sir.
Jaya Rani.
Yes, Jairani.
Jaya Rani
Jairani
is also
Kamraj.
contesting.
Yes, sir. Jayarani is.
Yes, Jaya is contesting for post of this
No to
Violence.
Violence against women. Wow.
women. Yes.
Sir, this time so many contestants are there
Good,
and
good.
a tough competition is there.
Since I am working in Foxy, I was always admiring people coming from smaller society.
Yes,
If
sir.
anybody is coming from smaller society,
As such, no
I am always to
representation
guide, I
from
am
Andhra
always to
Pradesh,
help,
sir.
I am always to
Till now.
support.
Sir, as such,
Thank
no
you, sir.
representation from Andhra Pradesh till now, sir. You
Yes.
must give us a chance, sir.
Oh yes, no, you are a hard-working person, so you are most deserving person.
Thank you, sir. So, Shanta,
But
will you
you all
conclude?
will reciprocate next year. Huh?
Shanta, will you
Yeah,
conclude?
Radha.
Conclude.
I am here.
Radha and Santa madam, you all will reciprocate next year.
Yes, sir,
Okay,
definitely,
sir.
sir.
Sure, sure.
Definite, sir. Definite, sir.
Without any
100%.
hesitation.
Oh
Yeah.
yes.
We have to reciprocate, sir. Thank you.
Thank you.
So
Thank you, madam.
now I think the session has come to the last part of today's webinar. And I really, from my bottom of heart, I really thanks to the guest of honor, Dr. Durgadas sir, who, despite of his busy schedule as a president of Kasoga, he has to attend to so many conferences, and he takes the presidential address every month. He accepted our invitation and he presented himself at the webinar and he graced our webinar. So I am very, very thankful to Dr. Durgadas sir. And also I am very thankful to Dr. Charmila Ayavu. With just one single call, she nodded for the webinar. That is her greatness. And next is our Dr. Vijaya and Dr. Radha, my co-host in arranging this webinar. I'm very thankful to both of them. And the Dr. Aruna Suman and also Dr. Umayal, the chairpersons. They were the chairpersons for today's webinar. I am really thankful for them. The
Finally,
next one is Dr. Bharti ma'am from the north, who was the main speaker of today's webinar. And because of her vast knowledge of intrapartum fetal surveillance, what she imparted to our members, that was really worth. And from my bottom of heart, I thanks to Dr. Bharti ma'am, and I wish all the success for her in her future endeavor. The same is to Dr. M.C. Patel sir. M.C. Patel sir, who is we asked him for the guest of honor with Dr. Asranna, but see, look at his politeness. He simply declined it and he said, see, I will be okay as moderator. We were taken aback. See, for small things, when one arranges for the webinar or anything, for the orders and all that, there are so many ego problems. But our M.C. Patel sir, he is so honest and down to earth, sir. My sincere thanks for his joining. Then the experts, Dr. Venkatramana and Dr. C.V. Ramarao, who gave their expert opinion on the panel discussion, and the panelists, Dr. Manjula Raghunandan, Dr. Shailaja, Dr. Nishi Vinutha, Dr. Radhika Kurapati, Dr. Baby Shalini, Dr. Pandurangaya, and Dr. Sushma. These all colorful people, young and enthusiastic one, who really decorated our panel, and I am so thankful to them. My sincere thanks to all of the members, all of the participants involved in this webinar. And the lastly one, I am taking this opportunity just to request you all to support me in my venture of chairperson, Public Awareness Committee Chairperson, POXI 25. So please support me, as well as please support all the other candidates here, Dr. Vijaya, Dr. Radha, Dr. Bharti, Dr. Umayal, Dr. Aruna Suman, and who is not present here, that is Dr. Jayarani also. Thank you all.
Thank you all. I request you all your support. Thank you so much.
Thank you.
Vijaya, you request yourself.
Yeah. Yeah, it's understood, no, the way we are calling them, and I hope really they should see and vote. That's what I feel. And your people, all are your people, and I request Andhra, Karnataka, Telangana people to Tamil Nadu, of course, they will know me, but these people won't know me, so I'm just requesting them, please support me. And
we will create support for you. Don't worry.
Yeah.
We are already doing that.
No. Umayala. Tamil Nadu people don't know us. please support from your
No, no.
side, Tamil Nadu.
I was just thinking now. I will call all the presidents and secretaries, and I will call you people. And I was just planning, thinking, I will plan one seminar like this for all of
Yes,
you.
yes, yes. You must do along with us.
Let us support each other.
Yes,
Definitely. I was just thinking now, like I will do one similar thing, and I will call all of you.
Grow with it. That is the life.
Okay, we will definitely support you, madam, all.
Thank you, ma'am. Thank you, sir.
Thank you.
Thank you, Patel sir. Good night, sir.
Thank you, sir.
Good night. Good night.
Thank you, sir.
Thank you. Thank you, everybody.
Bye, Shantamam, Radha, Umayal, bye.
Bye,
Thank you.
bye.
Bye, bye.
Bye bye. A very good webinar. Thank you.